Yes, sir.
Yeah, Jailal sir, you please talk because you have to board the flight, I think.
Jalal sir. Ganguly sir has already joined.
Jailal sir, Dr. Ganguly has joined. You want to talk first? He's on the phone, I think. Agam, you start.
No, Dr. Jalal is logged
No,
in.
he has just unmuted. Yeah.
You start, Jayesh, I will start.
Yeah, he has joined, sir.
Dr. Jalal, you could give your initial remarks and then we would initiate the meeting.
Okay, okay. Just a minute.
Sure.
So, distinguished Secretary General, the leaders of Indian Medical Association, I am extremely happy to be with you at this moment. And in continuity of the legacy of having the programs of our K Memorial Lectures, today we are here to have a very eminent and very, very versatile leaders address here. Dr. Kangle, the chairman of the ICMR, the amount of knowledge he has, the amount of service he has done for the vaccination is always very commendable. I always cherish whenever I had an opportunity to listen to his lectures, because it will be always with packed with information, packed with knowledge, and packed with ideas where what we can do. So that when we wanted to have the program on the KK operation, we thought that this time we would also invite Dr. Ganguly to give us this wonderful program. Agam is one of his very famous colleagues. They work together in a lot of vaccine projects. So I'm sure in this era where we all believe vaccine is being the only tool which we have to overcome the COVID, we need to understand everything about vaccine, because so many questions, so many small doubts are coming from the minds of the people. The doctor should be able to give that clearance. So all that, definitely, I'm sure after this lecture, we will be able to have a comprehensive view. So on that ground, I thank Dr. Jais, Dr. Agam for inviting our beloved, very versatile, legendary Dr. Ganguly with us. I'm sorry I will not be able to be with you fully as I have to board the flight, but I wish all the best for this program to go ahead. Thank you very much. Continue, sir.
Thank you. Thank you, sir. Thank you for your remarks. And it's your greatness that you call me your colleague. I'm your student, and I would love to remain your student. Good evening, everybody, and I'm extremely thankful to IMA for giving me this opportunity, especially Dr. Jalal, of course, Dr. Jayesh Lele. Dr. Lele's blessings are with me for more than 2.5 decades, and I have lots to him. Of course, I thank the entire IMA team for giving me this opportunity to be here and to moderate a session where the talk is going to be given by none other than Professor Dr. K Ganguly. Late Dr. KK Memorial Lecture. What a giant personality he was. He will always be remembered for his contribution to medical fraternity. I remember doing a lot of programs with him, and just 2 days prior to his hospitalization, I remember doing a program with him on immunomodulation. And every time I have a meeting with him, I get amazed, I get mesmerized by his way of connecting mythology and the modern medicine. A tremendous loss medical fraternity will have. And to remember him, we have this series of memorial lectures. And I'm very happy that today's lecture is given by Professor Ganguly. Professor Ganguly is a Padmasree Bhushan awardee. He is a former director of ICMR. He's a former head Department of Experimental Medicine and Biotechnology with PGI Chandigarh. is Emeritus Professor of PGI Chandigarh, National Academy of Medical Sciences, that is GRIPMER. He is a fellow of Royal College of Pathologists, Royal College of Tropical Medicine and Hygiene, Imperial College, London. Also is the former president of Indian Society of Immunology, Allergy and Applied Immunology. I had the opportunity to work with him on Association of Physicians of India's project on adult immunization, and I got a chance to work under his leadership for more than 2 years. I get amazed by the clarity of his thoughts, the vast knowledge that he has, and moreover, his simplicity. I got to learn so much in my short journey with him. I'm sure all delegates today will get a small glimpse of his vast experience. Trust me, vaccination is the only strategy to end pandemic. We've been losing lives and been losing many lives. If we make rough calculations, we are losing one patient almost every 2 minutes in our country due to COVID. By the time we finish our discussion, maybe we would lose 30 patients because of COVID. We cannot rely on herd immunity. If we follow the herd immunity path, that means if we go by various calculations, 65 to 70% of the population will have to get infected. That means, say, even if we take it as 100 million, 60 to 70 million people will have to get infected. And if we count just 1 or 2% mortality, look at the huge deaths we'll have to probably witness before we develop herd immunity. And hence, vaccination is going to be the only strategy which will help end pandemic. And then comes a variety of questions. Should I take vaccine? If so, which vaccine to take? Can I combine vaccine? Do I need to revaccinate myself? How often would I need booster vaccine? Are those few of those questions that are bubbling in our minds. And to answer all those questions, we have the champion himself, a champion of vaccination, Professor Dr. Ganguly. And without wasting much time, I request Professor Ganguly to enlighten us on this important topic of vaccination, especially the COVID-19 vaccination. Over to you, sir.
Thank you, Dr. Agam and Dr. Lele, Dr. Jailal, Dr. Subramaniam. I'm very grateful to you to bring me back to this forum. I had done several such talks with when Dr. Aggarwal was alive. I think around a dozen of them, and was missing him sorely, and very grateful that you brought me back. Now, the vaccine is such a subject that every citizen of India, including my cook and driver, knows about it. So, very difficult to really say something which will be relevant and which we need to understand today. I gather that this is not a public meeting. I would not have talked this in a public meeting because I don't want anybody to lose their faith in vaccine. We need to keep our faith in vaccine. And because whatever data we have from some of the countries where at the moment pandemic is raging, like in Texas, in Florida, in Michigan, in USA, some of the part of UK, in Russia. So there are a huge number of countries where it is raging now. And India, when you are publishing your meter, even today it is just below 40,000. So I don't know why we are so happy that we have we may not have the third wave, or we have very less number of cases. In some of the states, if you take the hazard ratio, it is very, very significant, and hospitalization is also significant. But one data comes out very loud and clear that most of the hospitalizations and deaths are happening in unvaccinated. And the vaccinated, although they have breakthrough infection, significant breakthrough infection, they are escaping the death or severe infection. That's now changing a little bit. that if you have got one shot of vaccine, you are not protected. The breakthrough infection can lead to very severe malady. So you need to take 2 doses of vaccine. The problem is this, that there are different regimes and different things, and we are talking about 28 days, 8 weeks, 12 weeks, or somebody says even after that. And that's actually creates a little bit of confusion. And we need to understand that this large gap was not only because you got a better immune response, because we didn't have vaccine. Whosoever did the large gap studies, these actually there was a lack of vaccine at that time. So the idea was give first injection as quickly as possible to as many people as you can, and then you give the second injection whenever you can. So this was the thought process which was followed. And here this thought process was okay till today, when we have lot of other data, and we know that we need to have a robust immune response. And many people who get vaccination, although they may have got double vaccination, they don't launch robust immune response. Some of them are transplantation patients, some of them are cancer patients, or those who are getting hemodialysis, as well as those who have immunosuppression, as well as some of the older age persons. A significant percentage of them, even after 2 shots of vaccination, do not launch a major immune response. And here there is a catch. Immune response is measured through different methods. Like Abbott has now brought out an antibody test, and they claim that this is surrogate for immunity, and they say Israel is using it. Then we have 2 kinds of neutralization assay. One is live virus assay, and the other is a ghost virus assay. The levels are very, very different. You get much higher level in the ghost virus assay than the live virus assay, and people are interpreting them according to their own way. And then we have T cell assay. We at this given moment do not have a very robust T cell assay for COVID-19. It was developed with a great application for HIV. This was known as tetramer assay. And the same way for tuberculosis also, a special test has been developed. So here, both 2 kinds of T cells, CD4 and CD8 cytotoxic cells, where both are involved. Here, the assays with the COVID, because now we know there are multiplicity of antigens, is not that very, very clear. So when we call T cell assay, we do T cell transformation. We measure T cells, and they respond to spike proteins. But we do not know whether this is a deletion assay or this is a real assay which tells us something significant. So immunity is also measured by different people by looking at the virus suppression in the test tubes. So they use the serum from the convalescent subjects, or if it is an antibody like Regeneron and other, they use it and say that, well, this suppresses mutants by 60%. Somebody says that this suppresses a mutant depending on the vaccine which we are talking about. This also is not a guarantee that this is doing exactly what you are looking at. Test tube is something which is totally in vitro. In the body, there are so many systems which are working along with your immune system that measurement you do not get. So actually the live measurement after vaccination, that what's happening, that is much more better marker than others. So looking at that, my major submission even now will be that vaccines work. And whether it's a 60% vaccine, or it is an 80% vaccine, or it is 90% vaccine, if you give 2 doses, it works. But the catch is here that this mutant, Delta mutant, which we are looking at, it's a very strange bug. This actually is now infecting children, and some of them very, very seriously also. The children wards in Florida, Texas, etc., totally full ICUs. And when they have gone to ICUs, these are severe infections. And in India also we have data. The data is not that, is still granular, is not that robust. But in certain states, we knew that it is causing infection in children. We also have, we do not have the real data of breakthrough infections. Majority, these have come from the major hospitals that they have vaccinated, and they have measured that how many of the vaccinated people got it, got the breakthrough infection, and they have monitored it. But we have international data on breakthrough infections. It is very, very significant. So what do we make of breakthrough infections? Although breakthrough infections, I still stand by whatever I said that before, that it is that if you are double vaccinated, you will be protected from severe infection and hospitalization and death. However, some data is now coming up which is disturbing. Like the long haul COVID, there are now cases which are being reported where they got the actual deleterious effect 6 months after they had the COVID. So one of the major thing which comes as the fogging of the brain. One of the two systems which are affected, that smell as well as the hearing, and sometimes the eye vision. These are all related to nervous system, and particularly particularly the ophthalmic nerves or the olfactory nerves. They go through cribriform plate, and the virus enters brain. We have now data that enters brain. It goes to microglial cells. Through that, it goes to neuron. It causes the T cell activation there, and there is a cytokine response and inflammation of brain which sets in. So some of the guys who are getting fogging of the brain are having loss of memory, as well as they have a lot of IgG4 in their CSF, and demyelination, and the virus affects a lot of major triggers in their responses, and both temporal lobe, frontal lobe, etc., are all affected. So one of the extreme cases, so there are some cases where Guillain-Barré has been also reported. The Bell's palsy has been reported. This has been reported even after vaccination, as an after effect of vaccination. But with COVID, these have been reported. But one of the extreme cases is one of my very dear friend who is of the same age. After first infection, he got infected with COVID. Today, he is paralyzed waist downwards. He was walking around, he was okay, and everything has been investigated, whether he has got NPH or whether he got other, but he got demyelinating disease. And this happened, and after that, he had a COVID infection after first injection. He took a second injection also, but these neurological symptoms are a reality. It is happening in certain percentage of the cases. Small number, but significant number after even 6 months after they had COVID infection. If you have Parkinson's, if you have schizophrenia, if you have other neurologic symptoms, you may get much more severe form out of this. The second thing which is I want to say, that there are heart inflammation also. Some people even have needed a pacemaker. There are many conduction issues. The acute kidney injury has been described. There are fatty liver changes which happens in the liver. So the multi-organ involvement of blood vessels and others are there. So a certain percentage, like it happens in dengue and others, have an immunologic response coming up later, which is not tamed. And it is there. And one of the parameters which they look at is the IgG4, and look at specific COVID markers on that after they rule out the other reasons. So here, what I want to say that what is the role of vaccination in these cases, guys? Some people think that vaccination may really do much more harm, but because we need to get these toxic elements out of these subjects. So when we move in the future of vaccination, we might be looking at some of the biomarkers which should tell us that this in this guy after COVID, the immune response is absolutely untamed, and it may come up later, and we should keep a watch on them. And if we use a vaccine, there could be a choice of vaccine, and we might use a vaccine which might be little bit gentler than the total spike protein vaccine. So this is one point which I wanted to make, that vaccine is good, but for some persons we need to be cautious for the vaccine. And if we really come to know that whether we should whether these guys are fit for vaccination or not, we need to really look at this very carefully. So this is one point which I'm trying to make. So I asked a question and said that long haul COVID guys who have ADEs and who have immune responses which attack and which come up late, whether and there is fatigue, there are muscle weakness, many things which come to them. What is the role of vaccination in them? The second point I want to raise is there a herd immunity in mutants, in the cases of mutants? It is coming up loud and clear, at least from the American data, Israeli data, and other data, that as far as a mutant is concerned, it is evading herd immunity. Herd immunity is not developing as far as the mutant is concerned. It is nothing new which we need to think about. Like herd immunity doesn't happen in influenza viruses. You have to get them every year. The mutations occur. The mutations in the previously we knew that it has got a gene editing apparatus, the coronavirus, and the mutations are not that fast. But they mutate, the infectivity of this mutant is like chicken pox, very, very high infectivity. It also coalesces two lung cells together. So actually its spread is very, very fast and very, very different and also fatal. So in these circumstances, we have seen repeatedly that like Russia immunized its entire population almost. China also immunized its entire population. Israel immunized population, but still we were having mutants raging in some of those places. Not Israel that much, but in Russia, in some areas of China, and in some European countries, of course in the United States, it was raging. Although there is a difference, like the states which are 60-70% vaccination, they do not have that kind of a raging infection. But one of the questions which have been raised, that is, can we measure really herd immunity on basis of the assays which we are getting it, so that we say that 67%, 68% is positive, and whether we will seropositivity is there. So have we really reached herd immunity or not? I don't think with the mutants we will have herd immunity in India. We should be very, very careful, and we should open up at least for the next 2-3 months if we really want that in November, as it has been predicted, we don't have another wave. We need to be very careful that how we work, how we perform, and how we can go for work, how children could go to the school. It is very, very important, because children not going to school for 2 years now is absolutely devastating. But we have seen in United States where there are some of the governors are mandating that you will not mandate mask or vaccination in the schools and children. We have seen the effects. There are large number of children who are getting infected, teachers who are getting infected, and 2 teachers have died recently. So when we do it, we need to firstly vaccinate all the teachers. Now we can even vaccinate pregnant teachers. In India also we can immunize pregnant women. We should immunize 15 to 18, but now we have data, and maybe if US FDA clears that, the EMA and others clear that we can have smaller children also. In the smaller children, vaccination doesn't have any significantly bad essays. There's a large amount of data available for in this, but when the major regulatory bodies look at the data, they take some time, but it's going to come. So we need to do that. We also need to do a mask mandate. We need to sterilize the classrooms after the usage. We need to have open windows so that we have much aeration, and we should have small number of classes. So we should employ more teachers, because the cognitive development of children doesn't happen if they don't go to school. Many of the children don't get a square meal if they don't go to school. The meal doesn't reach their homes in India. In other places, it reaches their home, but in India, it doesn't reach their home. So this has been devastating. So I'm not saying that don't open up. Open up, but open up with a very strong plan and very strict enforcement. Like we subsidize, we give free ration, we give many freebies. I will give a supply of free masks to every poor person, those who will like to have the mask. So that they wear it, because otherwise they go on wearing it again and again and again. Sometimes they wash it, sometimes these are not good masks. So effective, it is not that effective, and many times it hangs because it is thick and they have problem in breathing, so it hangs from there. So they are wearing masks. They are complying. When they see the police, they push that up. But one of the things I will do, the mask is the most effective one. If you are with vaccinated people, the mask is effective almost 90% if both people are vaccinated. If one person is vaccinated and other is unvaccinated, it is 70% effective. So 30%, there is a problem with this. So here I will again say that one of the freebies which we should give to the poor is the free supply of reasonably good masks, which are easy to wear, which doesn't cause them problem while working. And every month supply, they should reach their home. And there is a method of reaching their home. Now we have Aadhaar card, we have home addresses. So except for the homeless who may not have an Aadhaar card or an address, we need to reach these to them so that they are protected. So with the vaccination, this opening up of the organization, I just took a example of schools, but for every sphere, whether it is a shopping mall, whether it is a cinema hall, whether it is gym, whether it is bar, we need to really do that. In some places, well, like if you have gone to a bar, or if you have gone to a place where you are eating indoor, you have to take out the mask. And sometimes you are sitting for 3 hours or so. And there will be unvaccinated guys over there. They are not checking your vaccination certificates. So, here we have to be extra careful that we need to have a circulation time that all the waiters and everyone should have masks. They might have to be they are not individually served. You put the plate on them, and the rotating time restricted to maximum 45 minutes or 40 minutes. You eat, you enjoy, but not more than an hour. Don't sit there for 3 hours and then get those clouds forming because of the air conditioning and you get infected. So for everything, I took two or three two examples that how we can marry vaccination along with some practices of opening up. We need to open up because we can't get destroyed economically, but we need to do that. Now, another question. So this is one second question which I handled today. Third question. The first one was vaccination in the long haul people. Then the vaccination, and the mutations, and vaccination and the opening up. These are few of the things I took up now. The third one I will take up, the mixing of vaccination. The data which was prematurely released was 18 accidentally given 2 vaccines. Now, I will be very worried about that because all of you are physicians and doctors. You know that if two things mismatch in any case, if it is blood transfusion, if it mismatches, the person dies. The same way, if there is a mismatch in a drug or other, the person dies. So that means that our vaccinators in the rural areas or the peri-urban areas are not that well trained, and they can do these mistakes in the future also. But the data which came up that you can mix and you get a immune response in any case. I will not, there were 18 subjects on which this data was made. But the vaccination mixing happens only on one situation, two situations. One situation is this, that you have a shortage of vaccine and suddenly you have immunized certain population and they need a second vaccination and you don't have that vaccine anymore. So you may have to give the other vaccine. If that vaccine is available, you never mix, because the schedules, dosages, trials have all very, very different. The trial, of course, is done. India also has ordered a trial where you know that if two vaccines mix, they don't interact with each other, they don't react with each other, and they are safe and their safety standards have not changed. But essentially, the mixing is done. The major thing was done by AstraZeneca and Pfizer in UK. Because at that time AstraZeneca supply was very low and they needed to give the second dose. So they conducted a study and they gave it. In this fashion, there are some major global data where it has been seen that second dose can be given, but what I will suggest that second dose should be with the same vaccine, should not be with another vaccine, because manufacturers are different, their regimes are different, and the trials were different, and with a short trial, you don't mix it until unless logistically it is needed. It is also needed for some persons who have who become ineligible for vaccination, like young ladies who have a thrombosis problem or a deep vein thrombosis or other things, who cannot be given AstraZeneca. They cannot be given even Johnson & Johnson. There is a label claim. They cannot be given even Sputnik Light, which is exactly like Johnson & Johnson. So there you may think of giving another vaccine. So this is something which we need to really look at and see that we understand the mixing of vaccine much better than what we actually interpret it as. The next question which I will be asking, do we need booster? Now, the US FDA only yesterday had cleared the giving of booster to the immunosuppressed persons. Israel, USA, Germany, Europe, Germany, etc. have expanded it to those 60 and above also, apart from the immunosuppressed. Israel is giving it to others. Pfizer came out with the data, and Moderna also came out with the data, and they have a huge data set. And they have submitted it to the US FDA that immune responses start waning after 6 months. So what they are saying that give a booster at 6 months to those who need it. Israel has got a huge amount of data. Israel has got a beautiful data set, which they have made it public now, that really it wanes, and they are giving booster to everyone. With whatever people say, they are giving booster to all their citizens, and their immunization rate was very, very high. So booster also is fraught with logistics and public opinion. Like in America, when more than 1/3 are not vaccinated, there's a vaccine hesitancy. As soon as you talk about booster, people say the vaccine doesn't work. And so why should we take a vaccine? In India, we already, although we have immunized the largest number of people in the world, about 55 crore people we have immunized, but a huge number of those whom we have not immunized. And at this time, if we talk of booster, when there are vaccine shortages, there are supply chain issues, there are issues of the inventory management, it will be very, very difficult and cruel to say that you give a booster. So we are not talking of booster in India at this given moment, except on the TV shows. But booster will be a reality. And at least we should have a plan laid out, or a footprint plan laid out, where if booster is needed, we are able to give the booster next year when we have a large amount of vaccine, and we have plenty of vaccine within India, which might happen in 2 to 3 months' time. So here, in my opinion, we will need a booster as we need for influenza viruses and others. And although we cannot talk about it, we cannot talk about a policy, but we need to move towards that. When we are talking of booster and when we are talking of influenza strains go on changing with the sequencing which happens, the data which comes up, they go on changing, and the regulatory parameter is very, very defined. You don't have to go through the entire regulatory mechanism. The strain change is allowed. So major vaccine manufacturers at this time have created created vaccines against mutants. They have it, and they are in trial also. So the issue will be that should it be a cocktail of Wuhan strain and a mutant strain, which is prevalent of that time, the booster, or it will be the same Wuhan strain and others. So we need to settle this by funding elegant trials on these. So we need to go in trials for other site trials which are happening for the vaccine in the world, and should not just depend on small bridging trials which are happening for the vaccines which are being released in our midst. So this is where we need to be very, very careful of how do we do it. So then I come to, and after moving from booster, I come to another question which might be plaguing everyone. that could we do a little bit better regulation and some policy changes and other kind of systems which will make the vaccine availability very good. Our vaccine hesitancy is mostly in the rural areas because essentially our communication strategy has to be very, very good. Our NGOs need to be involved so that they they are able to talk in the rural areas. They are able to talk to those who are tribal or who are distant populations and vulnerable populations. Even the armed forces need to be talked to. But only hesitancy is over there. Rest are actually lining up for vaccination. And many of them have a digital divide. So they are making up large queues and other things because even I, if I need to use any significantly my cell phone and other things, I have to go to my nieces or young girls to help me. When I'm not able to do that because I feel even I am not able to call Ola very effectively. Many times I fail and they don't show up. So there is a population in India who are well educated, but they are part of the digital divide because you have to be very quick. Like when there was a vaccine shortage, you wanted to go to COVID, and there was a thing, that you need to get into by 12 o'clock or other, you need to do it. Within the time I used to put it in, everything was already booked. So with 10 different attempts, I failed. But ultimately, because I'm a healthcare worker, I got invited and got my vaccine. But I know what happens to my driver, what happens to my cook, what happens to others. So I shudder to say that what happens to others. There need to be facilitators. There need to be others who can really cover this vaccine. Because if we really want to go to the equity, we need to see that that those who are homeless, those who are rural, those who are migrant, because they will be spreading the infection very, very high. So in these circumstances, we will need that they are vaccinated appropriately, whatever is the strategy. And vaccine should reach very near of where they work or where they stay. When I say very near, because if they spend one day in getting vaccinated, they lose the wage. And so many countries have launched lotteries, gifts, money as an inducer. We do not have those inducer over here, but at least nobody should have a wage cut while they get it. So coming to again the regulation, there are now very large number of vaccines which have gone to very large populations, in billions even. The Pfizer, the Moderna, Johnson and Johnson, now some of the other Sinovac, Sinopharm, many vaccines which have gone through very large populations. And there is a large population data, the live data which is available. Why we need to have and ethnic Indians are everywhere. A very large part of ethnic Indians, more than 1,600, which we have done for Covishield here, are actually have been vaccinated in UK and many other places. So we have data of ethnic Indians also. So when we have this data, this pandemic is global. We should have a regulatory mechanism in which we can access as many vaccines as possible. There will be a question which will come up that some of the vaccines will be costly and will not be available to poor subjects and others. So, but there is a huge amount of Indians. You know, Indians have largest number of millionaires or billionaires around the world. About 350 million Indians can afford healthcare anywhere. They buy healthcare and they can buy vaccines. They should always buy vaccines and in a competitive way if they want to make a choice for vaccine. I will come to the choice a little later. One will say that then do the others be deprived of vaccines? No. Nobody should be deprived of vaccine, but the vaccine which these guys buy and get it, that money will go to immunize the poor, because even poor are now, so many of the poor are paying and getting vaccination, because they have to queue up and they can't lose wages every day. They can't go 3 or 4 days continuously. So this will free them up. This will free up the vaccinators, because those guys will be getting vaccinated in pharmacies, in the doctor's clinic, many other places, those who can pay and buy, and so the others will not. So we need to look at regulation, we look at the safety data and allow many of them to come. The one of the other clauses which is killing us is the indemnity, because we put up a lot of strong thing in the medical insurance as well as other issues, and these issues say there is an indemnity clause that, but in vaccines we never implemented any indemnity. Like you see the children's vaccine in some of the states, the children death rate is 46 per 1,000 or 35 per 1,000, and there some children will die even if they have not given any vaccine, any drug. They will die of many other causes and die after vaccination, and never indemnity clause has been. So our risk benefit ratio is normally invoked, no indemnity has been invoked. So we need to be very clear in our policies of bringing in vaccines, so that we are able to immunize our largest number of population as quickly as possible. So this is one of the strategies which our regulators should look at and see that. But even if we want, we can't. Like now we have cleared Moderna, at least. The Pfizer is still under discussion, but we will get it only 2022. You will not getting it in 2021, because vaccine scheduling of manufacturing, you need advance orders. So giving advance orders, finding out the money for vaccination is very, very important. So how do we find that money? We can find that money from various sources. We are increasing the taxes on tobacco. We are increasing the taxes on alcohol. All these are health pharma. We could put some on, or we can put some thing on the internet and others, which some of the countries are thinking. These were not our normal revenue sources, and we could see that whether we can provide vaccine really free to everyone who needs it. About 800 million Indians need it, and some Indians are so poor, the agriculture labor, the migrant, the homeless, the tribals, they just can't afford it, and we need to really see that they get it. So we need to have a better regulatory policy, better import policy, better distribution policy, and better communication policies to make the vaccine work as quickly as possible. We just can't afford to have 40,000 cases a day, and gradually these spread to other places as it is spreading with the other ones. So this is something which is very, very important in the vaccination strategy. My last two points or 3 points, which I will make very short, that one of the points is this, that whether we could give a vaccine choice to people. For all other vaccines, we have given choices. Problem is that we have some vaccines, and let me be very clear that some vaccines are better than other vaccines. But it is very, very clear. We know it. Every one of us know it. But we can't talk about it here, because the people, if we give a choice and say that this vaccine is better than other vaccine, there are global data. For all the global vaccines, there is a global data, and we know this. So can we give a choice to those who can afford and can do it? In 4 months' time, we will have several vaccines. We will have Zydus Cadila vaccine, we will have Johnson & Johnson vaccine, we will have Sputnik Light. We will have several vaccines which might be coming, maybe Moderna, maybe ultimately Pfizer. We will, and the Novavax is also under, it has not got at the moment, US FDA has not given it a clearance as yet, but it is ultimately we will get it. So 3-4 months we will have plenty of vaccine, and at that time we have no no method in which we could prevent people exercising the choice. But those who are getting free vaccines, we should say that quality-wise, all vaccines work, quality-wise, all vaccines are good, and we can do this. But those guys who are, even our grandmothers who can do their own research and find that this vaccine is better than other vaccine, they should pay a premium price to get the choice. And with that premium price, there will be an ethical question. Dr. Lele is here, others are here. There will be an ethical question. We need to discuss threadbare and we need to agree. But if in our hospitals, like even Christian Medical College Vellore has got one tower, which is for the those who are coming from Middle East, stinking rich, they are paying hotel rates, but that money is covering so many poor in this. In majority of the hospital and other structure, this works. Why not in the vaccine? So that every Indian gets it and supply chain, etc. problems are. So we need to have an ethical debate on whether we should give a choice to people for getting a vaccine of their choice. So my other question will be that that was what else we need to do to really make vaccine relevant. We need to do better sequencing. We need to do it as the Britain does it, as some other countries are doing it. We do sequencing, but we are not even 5% of our sample we are sequencing. It has to be done on time. It has to be done in a public health fashion. It has to be done to even tracing and tracking to get hotspots, to even find out protocols for better treatment, better vaccination. All of these will be needed if we have a robust surveillance. Surveillance should need to the institutions and organizations which are supposed to do surveillance. The CDC does it in USA. CDC China does it in China. The similar structures does it in other countries. So I will really strengthen our CDC. We'll put up region-wise NovaSeq and other sequencing machines, and will train them with a crash courses, get bioinformatic people even from the abroad, and we will do it. We should also do it globally in the global sample. So we should have a relationship with GISAID, because this pandemic is a global. People are transferring from one country to another through people. And if this is happening, we have to do this surveillance better. We have to do the surveillance in the wild animals also, environment also, environment in the backwaters, in the sewage and others. Bangladesh is doing it. In polio, we have done it. So if we do it, even when the numbers are less, we will find them jumping up in the sewage. And this will give us about 2 months advance notice that we will have an outbreak, as it happened in polio. When Bombay didn't have polio, the Bombay sewage, because from the migration from UP, Bihar and others, was full of polio viruses. And when it was jumping, the outbreak happened with the cases. The vaccine-derived viruses, which will also come through surveillance. In the polio, it is a reality. These today, in the polio 2 have started circulating in a vaccine-derived fashion. So we need another vaccine now, which a committee is considering, that we, apart from IPVs, we need to manufacture another vaccine. So this is something which is also again a reality. The other reality which we need to really consider is that what do we do next year? We need to do our primary immunization. We have to do our polio immunization, which will be IPV, which may be hexavalent polio also. At least 2 injections India has decided to give, and we will have to give corona vaccine also. There will be no escape. We will have to live with it for now several years, maybe in perpetuity as influenza is done. So we will have to really do this. We will have to. We may have to have a school, the children vaccination program. We may have to even include it in EPI. So are we ready for that? Has IMA and other our major organizations are they focusing and raising these issues to the government or creating their own thinking? In United States and others, there are academies, there's the Institute of Medicine and other which are doing it. In our country, we have the Academy of Pediatrics, the other learned bodies, Association of Physicians, IMA. We have also, they need to change their roles and rules to really make this happen. My final thing is that we need to do, if we need to really succeed in health, I will not deal with the monoclonal antibodies which are developing in India, but I'm tempering to say that there is a company known as Icera, which is there in Nasik area, in a very remote rural area of Maharashtra, which has prepared a Fab2, a very high quality Fab2, which is undergoing trial for the spike protein. And this is now being manufactured by Serum Institute and is undergoing trial, will be available much cheaper and much better price than others. So there are other things which are having, there are new drugs which are coming up. So we will have drugs and vaccines maybe in the future, and we need to marry them. Even for drug to work, sometimes the vaccines make it work. So this relationship today, because I have run out of my time, I will not deal with it. I will finish by saying that we need to immunize our healthcare workers. We need to really find out better working conditions for them. We need to really keep them ready. I have done, many of you might have done a locum in UK. I have done locum in UK before getting the fellowship or before getting a job. And if I used to love to work on Saturdays, Sundays, because I was paid double or sometimes triple, and sometimes got into a car and went to other areas. Every hour I worked more, I got paid for that. So here our healthcare workers are working for 46 hours, sometimes more. Particularly the junior guys are working. Senior guys are doing online consultation. These are the junior students who are working like this. We need to really make them safe, get them vaccinated, also create work conditions from them, because vaccine alone, as we have seen, there will be breakthrough infection. There's some very new data which has come up in breakthrough infection, that in the vaccine, you will still have almost the same amount of virus in your nose as the fresh infection. You will be able to transmit it. So our healthcare workers will be transmitting it to their granddads, to dads and others. But the good thing is this, that this buildup in the nose is for a lesser time period, very short time period, those who are vaccinated. It gets rid of them, but it is there. So please improve the lot of our junior healthcare workers, find out a method that they are not forced, they do it voluntarily, they do it lovingly, and they get paid and they get vaccinated. So with this, I will finish my talk. I normally raise questions because so much more is known about vaccination, that which are bothering people, and try to find explanation along with the global data sets which are available. Thank you.
Thank you very much, sir. That was indeed a very lucid presentation. You covered all aspects of vaccination and you put every mind working. I'm sure there are Lot of questions there. I'm sure a lot of people would want to clear their doubts, and I put house open. If there are any questions, if there are any queries, you have the right person in front of you. Please shoot your questions. So, sir, by the time people come out with their questions, do you think we healthcare professionals need to take a booster vaccination? You have given data, you've spoken about a lot of things, but if you have to advise me, or you have to advise one of those doctors who's working in the COVID care day in and out, we have finished our first vaccination. It's almost 6 months since we took our first vaccination. Would you recommend a booster vaccination if policies allow to take that vaccine?
Now, actually, our policies come out after a very, very long time. Actually, you as an association, as a learned society, should demand it. You should get it. My antibody levels are 12 after 2 doses. It is only 12. And 4 months have passed after I took the 2 doses. I'm scared. I'm going every day to the hospital. I'm really scared going to and coming in contact with the people. And I'm an aged healthcare worker, not even a younger healthcare worker. So if I was to make a decision, I will give booster to every healthcare worker at 6 months time.
Okay, sir, in continuation of the same question, would you recommend the same vaccine, or would you recommend a vaccine of a different technology? I understand you gave in your presentation that mixing of this vaccination may not be the ideal thing to do, but then given choice, say if somebody has taken Covishield 2 vaccines, would you recommend a booster dose of Covishield, the same vaccine after 6 months, or would you recommend a different technology after 6 months?
And unless you cannot take the first vaccine which you had taken, I will say the second vaccine should be the same. You could switch in the booster. You could switch to an entirely.
No, I'm saying, so somebody has finished the first course of vaccination. Somebody has taken both vaccinations. Say somebody has taken both co-vaccines, or somebody has taken both Covishields, and now 6 months have passed. Would you recommend the same vaccination as a booster? Or would you recommend a new vaccine?
You could take a different vaccine.
Yes.
Particularly, suppose I have a cocktail of vaccine which has a mutant and which has a Wuhan. Correct. I will prefer that. And suppose at that time there is a messenger RNA vaccine which is coming out of Genova in India, and BioE is also has contacted a Canadian company which has a messenger RNA vaccine, and a German company messenger RNA vaccine are coming to India with different kinds of contract, and the CIPLA will be bringing in Moderna. So if these are coming in the healthcare workers, at least they should have a choice. Those healthcare workers, at least who are working in the private sector, private individuals in the private hospitals, in the nursing homes and others, they should be given a choice of what you are using. Government sector, government can make a policy and provide it to them, but booster could be different.
So now there are a lot of interest in vaccine as a treatment for COVID. Would you throw some light on it?
There are therapeutic vaccines, okay, but there are several diseases where there are therapeutic vaccines which are given as a form of therapy. For Leishmania, I'm one of the advisor for Paul K's vaccine, which is undergoing in Sudan. It is a disease modifying and a therapeutic vaccine also. So as we know that monoclonal antibody cocktails and others are being used as a therapeutic entity. They are antibodies only. They are only immune responsive. The CAR T cells, etc. There are some trials which they are done in cancer. Some trials which are going on COVID also. So why not there? But for a therapeutic vaccine, the papilloma virus has a therapeutic vaccine also, apart from the preventive vaccine. But for therapeutic vaccine, the design is slightly different. they need to work on the cell-mediated immune response much more than the antibody responses. And their route of administration is sometimes different. They need also a thorough trial. At the moment for COVID vaccines, some therapeutic vaccines are under drawing board. Some have even advanced. But at the moment, we don't have a therapeutic vaccine. But if we have a therapeutic vaccine, we have to be very careful. It will be a humongous regulatory task because the COVID long hauls and the long term infections are just like dengue. That first week you get through, you are okay, but then after 10 days, 11 days, or the end of the month, you start getting. In COVID, it is much worse. You can get it after 6 months. You can get it. You could have a lethargy. You could have others for symptoms, but for 4 months, 5 months, 6 months, you could get it. In chikungunya, which does autoimmune bodies, you sometimes have years while you suffer from them. So here we have to be really very, very careful. One of the vaccine development where I was involved in internationally, that was a group A streptococcal vaccine. The M proteins cross-reacted with the sarcolemma, and there for 4 decades we struggled for the. Now that struggle is over. It has been found that you could have epitopes which will not have those things. So here it will be humongous task. I think we will have to get global expertise to really study those. We do not have that kind of expertise in India, although we have very good immunologists in India, very good people in India, but they have not been cutting their teeth on the regulatory requirements. This is a very strange, big issue, and they need to really learn that.
Thank you very much, sir. That was fantastic presentation, and your ideas, your views. You did not use any slides, and you give extempore talk. Speaks about your in-depth knowledge and clarity of your thoughts. I must thank IMA for giving me this opportunity, and I must thank Ganguly sir for enlightening us. Thank you very much.
Thank
I
you.
close this
Thank
program
you,
today.
Dr. Agam.
Dr.
Thank
Jayalal
you.
is in the flight, and Dr. Lele is not yet reached. So I take the
Thank you.
pleasure of
Thank you.
putting it on.
Thank you
Thank you,
very
sir.
much, everyone. Thank you.